Discover KDH Collective's Leaning into Therapy podcast, an enlightening exploration of therapeutic approaches and evidence-based protocols. Join us as we delve into the vast landscape of therapeutic interventions, guided by the belief that collective intelligence surpasses individual expertise. Led by Katie Holmes, a licensed professional counselor with 16 years in private practice. This series offers valuable insights, expertise, and training from a team of skilled therapists. Prepare to immerse yourself in the world of therapy, created exclusively for therapists by therapists. So today, Monet will interview me. So you want to?
How exciting. The roles have reversed. It's going to be great. I love picking your brain. I feel like we function so differently in the therapeutic setting. You're very much a behaviorist and I am not. But I think that there is this marriage that happens when we consult with one another that is really helpful. And so I hope that those listening or viewing take away something. Like I always take away something when we talk together.
Man, I love that because, oh man, I think that I was such a purist about behaviorism, when you're alone working. And then when we started working together, it started like really opening my mind to how important the relationship is because you are so relational.
I am. And I feel like I've taken a page from your behavioral book and I actually have come to enjoy applying behaviorism when necessary with my people. So it's been a very good experience. But we are going to talk specifically about obsessive compulsive disorder today, which is your specialty.
Yes. Yes.
So why OCD?
I talk about this a lot. Probably I've already had videos on it, but when I got introduced to it, I had a client, I didn't know what it was. And they were pretty severe symptoms. They went to a psychiatrist. The psychiatrist didn't catch it. They were hospitalized, I know. And then it was caught. And at that point, I was a new therapist, maybe like 3 years in the profession. And I was like, how do I not know about this? Right. I mean, we go to school, we get out, we think we know so much, right? But there's so much more to be known.
Yes.
So yeah, that put me on this whole, I consulted with another therapist who was like, oh yeah, that's OCD. And I was like, how does she know? And I don't.
Mm-hmm.
Yeah. And so that just led me down the road of
So
learning.
how long at this point have you been working with OCD, so to speak?
I'm
I
so
know.
bad with time. I'm really bad with time. I have been a therapist for 20 years, which is bizarro. I know. I know it's weird. I was
You
thinking
must
about
love it if you're still
I
doing it.
I do, but it's not like a thing where you ever know everything. So the more you know, the more you realize you don't know.
Mm-hmm.
And there's something about that I just love. The deeper I get into the profession. So it's a weird 20 years, but maybe 12,
Informal math, like 15 years? I don't know. 15 plus years doing OCD work?
probably or 12. I don't even
Okay.
know.
At
Yeah.
least a decade, if we're
Yes.
being generous.
Yes, it took me forever to get the right training because it was so hard to get into. So that was a really big barrier. So I had to read books on my own and try to understand it on my own before. Yeah.
Okay. And OCD is not a monolith. There are different flavors of OCD, which I think the general population isn't aware of. It's often which I know every OCD practitioner in this practice loathes when somebody's like, oh, I'm so OCD. I like my things organized. That is what people think of when they think of OCD, but kind of educate us. What does OCD look like? What are the different flavors of OCD?
So there are a lot, and for every subtype is what they call it, there's more that come out. Like recently I saw false event OCD. This is where people obsess about if an event actually happened and it's not a real event. There's
Mm-hmm.
real event OCD where people obsess about an event that happened. Um, that actually happened. And then there's retroactive OCD, which is another newer one I heard about. This is where people obsess about what their partner's done in the past. But the most common ones, those are just some of the newer ones, right? The most common ones, the just right OCD, like we talked about, that's where people visually like things just right. And it's completely subjective based on how it feels inside of them. Sometimes it's like perfect for everyone, and sometimes it's not. But it's based on a feeling, can be just right on how they feel walking in a room. I mean, for every person, there's a different version of OCD. There's also pedophilia OCD, which is a more taboo form of it. People obsess about if they're a pedophile or not. They'll look across a room and they'll see a kid's butt and they're like, oh, I'm a pedophile.
Mm-hmm.
Um, and then they're obsessing about that. There's also harm OCD. A common one in that is people drive over a bump and they're like, oh no, did I just kill someone? And so then they go around the circle and they're like, oh, I didn't. That's their compulsion, right? They're checking and they drive over the bump again. That's a really common one. The harm one, if some people watch a series on serial killers, then
Mm-hmm.
they're like, am I a serial killer, right? And so they start obsessing about these types of things. For people that don't know, it can be scary when you start hearing this stuff in your office, but super, super normal. Um,
Mm-hmm.
for an obsessive brain. They obsess about things that are bizarre in nature, and it's not a judgmental tool. It's just slightly out of the norm of what someone would worry about. Uh,
So for me, it's helpful to conceptualize like the bare bones of OCD in that there are obsessions present, correct?
Mhm.
And then there's compulsions sometimes because there's the phenomenon of true O. Is that how you say it? Where there's
Pure.
just obsessions?
Pure O.
Pure O. There you go. That's what it
Yeah.
was. Um,
Yeah.
so yeah, sorry, go ahead.
No, 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 you go. I'm sorry.
Well, to me, as somebody who's not an expert in OCD but feels OCD informed, I love to make that distinction. I'm OCD informed and not OCD competent. So I can clock it, as the kids say. I can acknowledge it and see it when it's in my office, and then I make the appropriate referral to you or anyone else who is more specialized than I am. I know to look for there are the obsessive thoughts and then the compulsive actions, and then those flavors kind of get put on top of that. And so the content of the obsessions is kind of what varies from person to person, as well as the compulsions vary from person to person. Would that be like an accurate
Yes.
description of it? Okay. Okay.
Yes. And I think that the content is based on what's important, most important to the client. So if they care about not hurting people, they're going to obsess about being a killer. It
Yeah.
really, it says so much about who they are as a person. Yes, and there is something called pure O, which is pure obsession.
Mhm.
I always think there's a thought compulsion, so I don't really abide by like a pure obsessive
Okay.
brain. I'm not saying there can't be someone, but most of the time there's some thought or internal compulsion happening, whether it's sensation checking, feeling checking, memory checking, but it's just not external, like tapping or washing your hands or
Okay.
moving furniture. Yeah. And the reason I abide by that, because if there is an internal compulsion, you can do ERP, exposure and response prevention, to treat it.
And that is the gold standard, correct, for treating OCD?
Yes, I love ERP.
Yeah. I mean, you got to be so self assured. Maybe I'm assuming too much, but as a clinician, when you have trained in ERP, you can show up for your clients in a really confident way to say, we can make this better for you. Like, is that the experience?
Yes, yes.
Okay.
And these, for me, I think my clients are more visibly distraught than other clients. There's something about OCD that there's a statistic that people that are diagnosed with it are 50% more likely to have severe symptoms. So 50% of those people are going to have severe symptoms. Moderate symptoms, 30%. So basically 85% of people with OCD are going to be moderate to severe,
Okay.
which is, I like that statistic because it informs what I observe. These people are so distraught. And so if
Mhm.
I can give them a tool confidently that I feel confident about, they will feel more confident to use it and their anxiety will go down. Yeah.
That makes a lot of sense. So it's a serious thing. It's not just about being tidy and checking things necessarily. The content can kind of exist on a spectrum, as a lot of mental health phenomenon does. Um and I'm so curious, like the intersection of anxiety and OCD. Like, gosh, a clinician witnessing a client for the first time and they're trying to discern, is the client just experiencing anxiety, or are they truly experiencing some OCD symptoms? Like, is that easy to parse apart, or is that kind of a sticky thing in a session?
I think it's hard for people. I do. I think it's really hard as a clinician when we learn something. Everything is the thing we're learning about. Very common phenomenon. There's something called medical, I can't remember what it's called. It's medical something, but it's where medical students, when they learn about a diagnosis, they all think they have it.
Yes. Yes.
And I think therapists, we do the same, and we do the same with our clients. So it can be hard to differentiate between an anxiety disorder and OCD. But I think the easiest way for me, if it's bizarre in nature, that's my clinical, I'm like, is this a little
Mm.
odd?
Okay. Okay.
The ones that are more normal, they still present a little odd. So think there is relationship OCD. So people obsess about their relationship,
Mhm.
but what they're obsessing about or feeling anxious about is going to be like, do I love this person enough? Right?
Okay.
My feelings enough to stay with them. And it might seem normal, but you're like, that is a little odd. Most people don't worry about that. They might worry
Mhm.
about, is this relationship going to work? How long do we need to be together before we can get married or something like that? But they're not going to
Mm.
worry about their feelings being enough. Or I looked at someone and found them attractive. Does that mean that I don't love my partner? It's just a little,
Okay. I see what you're saying now. Like, that makes a lot of sense of just, well, where is this coming from? And then, oh, wait, hold on. This is a thought pattern that could be indicative of an obsession, basically.
yes. And if they
Okay.
have one, they probably have a history of others. Yeah. Because
That makes
one
complete
that
sense.
goes once one goes down, another one comes up kind of a thing. So
Ugh.
I want to say this other one because you deal with sexuality.
Mhm.
So there is something called sexual orientation OCD. This is where people obsess about their sexual orientation. And
Yes.
it's again, it's not like, am I gay? Am I straight? Right? It's
Mhm.
more like, what if I have to live like the opposite sexuality when I don't really feel that way? So it's kind of
Yes.
this turn on it.
It's was really interesting the first time that arrived in my office, right? Because I do promote myself as being LGBT affirming, competent, absolutely willing to go there with clients about sexual identity and gender identity, right? And it was very apparent very quickly that this was absolutely sexual orientation OCD. And I was able to provide psychoeducation thanks to you and all your wisdom that you've imparted to me. And I was also able to let them know, like, um, there's a treatment for this, right? So it's like, whether you are or aren't, whether you're trans or not, this is OCD, right? And so I need you to go get the appropriate treatment for that, and then we can come back and really start to pick apart the nuance of gender and everything like that. If it's still even an issue once you've done ERP for it, because oftentimes it's like once the ERP has been put into place, it's like, oh, okay, like it's not so distressing, it's not so disturbing, that kind of thing. They're not so distraught. um and that has been really helpful for my practice, and I think it could be helpful for anybody else who serves this population to know, like, there is a difference between sexual orientation OCD and gender dysphoria. There's a difference.
What is it? Yeah, what is it?
It's nuanced. I think it takes practice to kind of piece it apart. But I do think that for me, when you were describing the example, I think of checking. Checking to me is OCD. So if somebody comes in and they are obsessively, to use the word, watching homosexual pornography to determine if they are gay, to me, that's more OCD than gender dysphoria or sexual identity dysphoria or anything like that. If they are constantly watching that material in an effort to elicit some sort of response, whether it's physiological or mental, I'm like, that doesn't feel like just dysphoria in that regard. That feels like a compulsion. And so that's usually when I'm kind of discerning, okay, I may need to refer you on. This is what we're working with. Does that make sense? Does that?
Yeah, I love that. It's almost like the one is like a, I'm thinking of a metaphor. One's like a flower that's taking root, or like a
Mhm.
an awareness inside of us about who we are that's like it's inside of us. And the other
Yeah.
one's like a checking repetitive behavior of uncertainty
Mhm.
without like a dive in.
Yes, because I think with the gender dysphoria, it's this global sort of like, I don't even want to whisper it out loud, right? Because I might be manifesting it. Whereas with the sexual orientation OCD, that feels like a preoccupation and a distressing preoccupation. And it's that uncertainty, right? Which is like the killer of OCD is just like the gray. Like the gray is the worst thing for the brain. It's just like, oh, it could be, you know. And so that's what I'm usually looking for to make that discernment and treatment planning.
I love that. I think it's a really valid point for people that aren't used to working with OCD, because you could easily think it's like a true gender issue instead of what it
Mhm.
really is, which is OCD. And if it is OCD, they're going to have other obsessions. So this isn't going to be their only one, because
Right.
it really is what people do with things that they're distressed about. So it's the way that they cope, which is really not great, but they do things compulsively with things that are distressing. So yeah, really good. I mean, it could be the same with a relationship, I think. We could look at it as a valid, like maybe you are really uncertain about your relationship, but the more you dive in, it's actually not that.
Mhm. Mhm.
Yeah.
I want you I want you to info dump with me on
Okay.
OCD and all the things because I know you just have a wealth of knowledge and maybe you've never had a vessel to dump all the information to. So I want you to do that. Tell me everything.
Okay. Okay. So I'm gonna tell you as much as I can remember. My little ADHD brain, I wrote some of it down, but
Okay.
I'm going to start with it takes 14 to 16 years for people to get the right treatment. So to be diagnosed and then get the right treatment for OCD, and ERP is 60 to 85% effective.
Okay.
So what the fuck? I am saying a
Mhm.
curse word, like, come
Mhm.
on, people. We can do better. It is the fourth mental health disorder, I think, in the world. So I don't know what the first three are, but it's the fourth. I'm like, that's pretty high up there. The percentage of people that have it seems to be the same across the whole population. It's like 1.5-ish percent in the US, at least in the US.
Okay.
There isn't a lot of research on different ethnicities, which is really disturbing and distressing. They have tried so hard because of, I think, because of the bizarre nature of some obsessions, people don't trust systems to reach out to. I've had
Yeah.
clients not trust me because I'm white, and afraid
Mhm.
that I'm going to misdiagnose what's going on, um,
Okay.
as being psychotic versus no, you just have OCD. So that is kind of interesting. I'm gonna read some more of these. 12, 12% of ADHD adults have OCD, which is
Okay.
interesting, or vice versa. I guess it's like people who have OCD have 12% of those have ADHD. That's the accurate way to say it. You have to watch
Okay.
statistics.
Mhm.
Um, People that have OCD, 25% also, man, this is also have PTSD. So
Ooh.
I know. So I think it gets there. I'm going to say this quickly. Um, Everybody thinks everything is trauma. That is and I hate saying everybody, but right now that is the thing. Everything's
Ah,
trauma. Oh,
yeah.
I'm like everything, even when it's like there's no traumatic memory. Oh, they must not remember it. Um, I just think we don't have all the knowledge yet for all of that. And so, with that being said, it is our knee jerk to think that their OCD is from a traumatic event. It could be, but if you treat just the trauma, they will still have OCD. And so, there
Okay.
is like neurological differences that are contributing to this. So, just when you think of that statistic, 25% also have PTSD, be cautious. You still have to do ERP. Um, then the autistic adults that have OCD also, or basically, if you have autism, there's a 37% chance you'll have OCD as well. And so that's a pretty high statistic. That was the highest one. And when
Okay.
I read that, I thought, well, we got to be careful about how we're treating this, because can they have both? Yes. But I
Hmm.
don't want us to again, we learned something. I don't want us to overdiagnose autistics with OCD when it's just their preference for things. Like I had a client
Okay.
once who special interest was playing the guitar. They were diagnosed OCD. That is not OCD. That was
Mm-mm.
their special interest that they enjoy
Okay.
playing the guitar. That is not distressing. And so it's really important that we differentiate special interests and an obsession and compulsion and
Good
basic.
to know. Wow.
Yeah, there's more statistics. Depression is probably the most common co-occurrence that we should look for, or a depressive episode, even in children. It's really interesting.
Hmm.
Um, and then 25 to 35% of OCD patients also meet the criteria for major depressive disorder.
Wow.
Um, and so, with that being said, again, it's super distressing to have these sorts of mental presentations. And so I think being aware that it could create or cause a depressive episode, or maybe they're co-occurring,
Mm.
treating the depression is easier than
Yeah.
anxiety, and medicine can be really helpful in those populations.
Okay. Wow.
Too
It's
quick?
so no, it just sounds like we're still learning. And going back to what you shared kind of at the beginning, which I'm really fascinated by now, um, the societal influence on OCD, I never once considered. So the false event situation, which is like a newer phenomenon,
Mhm.
um, it feels like in response to the world that we live in now. And that's really interesting. So it's probably safe to say that we may see other types of obsessions popping up as we continue to grow. Like, I don't know.
Well, the false event one probably has always been. Like I've had
Okay.
clients when
Okay.
my very first OCD client, like that I truly worked with, had that. It wasn't a real event, but they were drunk, couldn't remember, and they kept creating this false memory sort of thing. But I think there's a term for it now. I don't remember a term for it in the past. And so
Gotcha. Okay.
yeah, they're just coming up with new terms all the time and new
Yeah.
treatments. I do want to say this one thing. I do not endorse any treatment that's not through the iocdf.org.
Okay.
It is a really helpful organization. They are the experts. That is who I was trained through. So there are some new therapies that are coming out that once they say it's a new therapy, I will endorse it. Until they say that, I'm not endorsing it. So
They are the end all be all for OCD treatment.
yes, and they do tons of research. I mean, even their
Okay.
brain stuff, because I love the brain, so I was researching what's going on in the brain. And the article through them, like I found information elsewhere that was like, this is what's happening, right?
Okay.
It's science, so it's really hard to read. But then I get to their article and they said it's just slight differences, right? So we think this is what is happening, but it's not definitive. It doesn't mean the brain's causing it. It just correlates. They're really objective when they take research and data, which I think we need, because it's easy to read the research like me and think, oh, this means that it's a lot of people and it's a major difference. No,
No.
neuroscience, it's a subtle difference. They're
Yeah.
just good at being objective. Yeah. So
Okay. Anything else that just tickles your brain about OCD that you want to share with us?
no, I just love this population. I have a
Yeah.
special place in my heart for them. I am a little obsessive. I mean, a lot of these people are geniuses. They're way smarter than me. And their obsessive brain sees details that most people miss. So I don't see it all as like a negative. I lean on this like neurodiversity affirming. It's a positive. If we can learn to maneuver when it is a problem, right? And because when it's a problem, it's a problem. But if
Right.
it's not, if it makes them competent in other areas, why would we
Try
want to
to,
change that?
yeah.
Yeah.
Wow. So I hear you really applying this like humanity, dignity first sort of approach. Not everything has to be pathological, especially if it works for them in their life.
I
Wow.
know. And this is especially true with autism. You got to just, I'm not I'm not going to change some of their differences. I have to accept it and work in line with what flows best for them.
I
Yeah.
mean, one thing I want to point out before we wrap up is, for what it's worth, like clinicians that are listening that are fearful of ERP because it is hard work, I will say it seems that your clients are just as committed as you are. Like, you have a very low turnover, because I could see where clinicians would be scared of, like, well, am I going to push the client beyond their capacity? Are they not going to stick around? Am I going to harm them? I think you do such a good job, and it's like you work with people for a long time and you make sure they are okay. And I think like it's the buy-in is pretty amazing. Is it that experience for you? Am I off base with that observation?
It's really sweet of you to say. I've never thought of it. It's kind of like that thing for me. I'm like, ah, yeah, I guess I don't really have a high turnover. People do stay with me. Um, I am very invested. I am. I'll do coaching sessions. If they want to do it, I am going to ride with them through that, whatever it is. Yes, I think it takes time to trust, but I do think over time that we become better therapists by learning ERP. Like, I'm not afraid of breaking my clients. I used to be real scared, like they were so fragile.
Mhm.
Um, People push back all the time, and I love that tug of war and that, like, because I don't know, I think it makes our job interesting. Yeah, there's something really human about that experience. So it takes time to trust in the process and to do it well so that you feel okay holding a boundary, but that will transmit into all your clients.
Absolutely.
Crazy. Yeah.
Yay.
Yeah.
OCD.
Yes. Thank you.